a significant burden for health in this country and across the world. And so I'm actually going to talk about the causative organism, human papillomavirus. So, so just bear with us while we get the so my first slide really is just to talk about conflicts of interest. I do I have worked and I do still work with the vaccine companies related to the HPV vaccination. I've worked with other pharmaceutical companies, and I've also worked with the Department of Health. So this is, how can I do this, because this is not moving on here, which is confusing me. So this is really just a background of my own career and that of human papillomavirus. So I'll just step over this side. So I went to university here in Cambridge a few years back, and when I was training in London, we were doing procedures for women with cervical cancer on a weekly basis. I did my doctorate in medicine in the mid-90s on the cervical cancer and aspects of the disease, and then came to Cambridge back end of the last century. So already over the first 10 years of that career here, we saw the impact of cervical screening and the reduction in the number of radical surgeries that we'd be offering for women with cervical cancer. We offered fertility sparing surgery for those women where it was suitable, and so I saw someone today who had their surgery for cervix cancer 2 years ago, and she had a little baby boy, Joseph, earlier in the year. So we are able to support women in their sort of normal behaviour rather than having really dramatic impacts on them. Oncocentra is referring to radiotherapy, so for those women who are unfortunate to have a very advanced disease, some of the techniques that we're pioneering in Cambridge actually are giving very good success rate. And it's not only very good success rate, it's also with much less in the way of complications. And then the patient that we were just talking about had keyhole surgery for her radical surgery, so hopefully the impact of the surgery was much less on her. So that's my development. Correspondingly, the vaccine, the virus that caused, the human papillomavirus that's caused genital warts was first discovered in 1979, and then the one responsible for most of the cancers in 1981. In 1988, the Department of Health tweaked the screening that was available and actually changed things so that GPs and women saw each other on a regular basis for screening rather than the haphazard screening that had been happening beforehand. 2002, it was recognised that papillomavirus was the cause of cervical cancer. 2006, the vaccine was licensed for use. And that started in the UK schools in 2008, and Professor Zerhausen got the Nobel Prize for his work on human papillomavirus in 2008 as well. And in 2012, the schools program then used Gardasil. So, that's... What's that now? So this is Professor Zerhausen in Heidelberg. He did some work, and the thing that was significant about his work in the late 70s and early 80s is when he discovered these viruses, he actually shared these viruses with other research labs around the world so that lots of people could work on it, rather than keeping this great idea to himself and then sort of pottering along in his own time. So that was an area of significant collaboration. It is a big problem, but actually 90% of this problem occurs in the lower economic countries. And this is a picture of El Salvador, the Pacific coast. It really is very idyllic. You've got the sea, you've got the palm trees, you've got the sand, and they have a population of about 6.5 million adult or people, and that's equivalent to Eastern region here in Anglia. And that population in Eastern region, or our population in Eastern region, has an instance of cervical cancer about 1/10 of that in El Salvador. And that's not because they don't have a health service, that's because they don't have an organised screening program. This is a picture of the various types of human papillomaviruses. There are nearly 180 types present, and they usually infect skin surfaces, basically. And the low-risk types that are associated with genital warts are here, ringed in red, and the cancer-related ones are here, ringed in blue. And the vaccines that we have available now can vaccinate against the red and the blue strains. So this is a picture of the virus, of how we think it looks. And the most important thing about this slide really is that pretty much all of us have been exposed to human papillomavirus in our time. Most of us actually didn't really notice it, shrugged it off, and there's no problems associated with it. So the infection is usually asymptomatic. Most of the time it resolves spontaneously, and it's really only the persistent infection that can cause cancer. And cancer itself is a rare outcome from this infection. So from the point of view of the virus biology, the virus is actually very well sorted out because it really has little effect on its host. So you have an infection, the virus incubates, there's an immune response from the host, and the virus is cleared, and that happens for most of us. And there really isn't, and that's exactly the same as things like flu or common cold, it's exactly the same. However, in HPV, there is this situation where we have some persistent carriage of the virus, which is associated, or thought to be associated, with the development of pre-cancer and then cancer. The previous slide really just separated out into benign and malignant disease, and it isn't just about cancer we're talking about. Genital warts are a very difficult problem to deal with, notwithstanding the stigma and psychological problems associated with the sexually transmitted disease. But these do carry quite a significant cost of over £30 million a year for the NHS. And this is a graph showing the increase in number of diagnoses, both in male and female, up to 2006. The significance of that is that we do have a way now of dealing with that. But then there's also the issue of that women give birth, and women who are sexually active get pregnant and may transmit the virus to the children. Now, recurrent respiratory papillomatosis is thankfully a very rare disease, but these are the vocal cords of a child with warts on it. And these can cause problems with breathing and speech, and are very costly to treat. And some children may require up to 30 or 40 operations a year to keep these under control. And this is really quite a significant effect, albeit very rare. Another relatively recent bit of work has shown that a common form of epilepsy that in very small numbers has very severe effects that require surgery to remove scars in the brain, have shown that there is an association with human papillomavirus. So this is a group of conditions which, albeit very rare, carry significant health problems apart from the cervical disease. One of the things in talking to colleagues around Europe and in the US is that they're really quite jealous of the National Health Service screening program. And certainly cervical screening and colon screening are really very positive, very successful. There are some questions about breast screening, but I tend to be on the positive side of that. And for men, or the older man, prostate screening probably is causing more problems than it's worth, because actually the disease doesn't tend to kill the older man. But certainly screening works for the cervix. And the trouble is, it does cost a lot of money. Cervical screening saves about 4,500 women's lives a year. So it really does make quite a difference. And this is some data really just looking at the incidence of cervical cancer in England is about just under 10, and in Cambridge and Norfolk it's higher. Suffolk is slightly lower. But the thing to notice is that we've got a very much lower mortality in Cambridge. So we're actually, for those women who do have the cervix cancer, we are actually treating them better. So these diagrams show the benefit of screening. In 1988, I said that this is where the screening was better organised. Screening had gone on in the UK from about the early 60s, but it was very much very patchy. In 1988, they linked women's attendance for screening with an automatic recall. And so the fact is that we're all very busy, and if you forget, you might, with all best intentions, you might want to remember what's happening in the next year or two, but unless you get a letter coming through saying, please come along, you probably will tend to forget to do that. But this organisation saw about 80% of women having their smears